Good morning and good afternoon, everybody. This is Rich Killowald with the American Cancer Society. Welcome back for the second of our 3-session COVID-19 and Cancer Echo series. Glad to have you back with us. A couple quick announcements before we get in today's call. Our expert faculty will be answering as many questions as we can live during today's call, so please use the Q&A portal throughout today's session to submit your questions. Depending on how you logged in, that might look a little different. Most desktop users, laptop users, and mobile users will see the question and answer feature probably at the bottom of your screen in the black Zoom bar, or potentially for some mobile users up at the top of your screen if you click on the screen. So please feel free to submit your questions. A quick reminder, all echoes do take place on the Zoom platform. You can review Zoom's privacy policy at zoom.us/privacy, and this call will be recorded today. So with that, let me turn it over to Dr. Laura Makaroff, Senior Vice President of Prevention and Early Detection at the American Cancer Society. Laura?
Great. Thanks so much, Rich, and welcome, everybody. Welcome back to those of you who joined us on Tuesday, and welcome for the first time for any of our new participants. We're excited about today's session. Again, I'm Laura Makaroff. I serve as Senior Vice President of Prevention and Early Detection at the American Cancer Society. I'm also a family physician by training. We're really pleased to be here today, partnering with the National Comprehensive Cancer Network, as well as CDC on today's session and this series around COVID and cancer for cancer care teams. So I do want to reintroduce our faculty for anybody who's new today quickly, and then we'll dive right into our didactic session for the day. So first we have Dr. Brooks, who's Chief Medical Officer of the COVID-19 response at CDC. Dr. Brooks is a medical epidemiologist and infectious disease physician with the Division of HIV/AIDS Prevention, the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at CDC. He's a nationally known expert on using public health research to improve the prevention and treatment of HIV infection. In addition to his work on HIV and AIDS, he has devoted many hours working on national and global disasters, including Hurricane Katrina, and most recently the 2014 Ebola response when the epidemic was really accelerating across Africa. We were seeing our first cases in the US. So we're really pleased to have Dr. Brooks with us today to provide some national guidance around the COVID pandemic. We also have Dr. Larry Shulman, who's Professor of Medicine and Deputy Director for Clinical Services and Director for the Center for Global Cancer Medicine at Abramson Cancer Center at the University of Pennsylvania. Dr. Shulman is currently also chair of the Commission on Cancer and serves on the National Cancer Policy Forum of the National Academy. He's also the former chair of the American Society of Clinical Oncology Quality of Care Committee and the Commission on Cancer's Quality Integration Committee. Next, we have Dr. Mark Stewart, who's Medical Director and Senior Vice President at the Seattle Cancer Care Alliance. As the Medical Director and Vice President there, he oversees all of their outpatient clinics. Over the past decade, his research has focused on the optimal use of advanced practice providers, drug safety in oncology, and clinical productivity. In addition to his role at the Seattle Cancer Care Alliance, he is also on the board of directors for the National Comprehensive Cancer Network and is co-chair of its Best Practices Committee. We're happy to have you with us today, Dr. Stewart. We also have Dr. Tom Varghese, who is Executive Medical Director and Chief Value Officer at the Huntsman Cancer Institute at the University of Utah. In addition to his role there, he is also a Program Director of the Cardiothoracic Surgery Fellowship and an Associate Professor in the Department of Surgery at the University of Utah. He holds national leadership positions in the Society of Thoracic Surgeons, the Thoracic Surgery Directors Association, the American College of Surgeons, the Society of University Surgeons, and the National Comprehensive Cancer Network. So that's our expert faculty today. Like Rich said at the top of the hour, please use the Q&A portal on your Zoom platform to submit your questions live today. And then we have a nice compilation of questions that were submitted through the pre-registration process. So we'll be using a mix of those for our Q&A session after our didactic presentation. So with that, I'll hand it over to Dr. Shulman for today's presentation.
Thank you very much, Laura, and welcome everybody. Thank you for joining us. And I hope that the next hour will be informative and helpful for you. If I could have the next slide, please. So I think all of you know, all you have to do is read the newspapers, that we're living in a very fluid time in regard to our understanding of COVID-19 infection overall, and certainly how it affects cancer patients. So I'm going to tell you what I think we know on Thursday, April 30th, 2020. And that could be different than what we know on May 1st, 2020, because things really are changing every day. I think that with current data, and I'm going to show you some of these data, it's not clear that cancer patients, either on active treatment or with a history of cancer, are more likely to contract COVID, though there is some concern about that. I don't believe the data strongly supports that at this point. It is pretty clear, though, that patients who have active cancer have a greater likelihood, if they become infected, of having serious complications or death from COVID. And I will also show you data that suggests that their infectious progression is more rapid than non-cancer patients. So this is a particular threat to the patients that you and I and many others care for every day. It's not clear whether cancer survivors are more likely to have serious complications from COVID infection, but my reading of the data is worrisome, and I've told my own patients who are cancer survivors to be extra cautious. Next slide. We also know that cancer patients infected with COVID undergoing surgery have a very high perioperative mortality. In some European studies, it suggests that 1 out of 4 patients will die after surgery if they in fact are infected. So many of us are now testing all of our preoperative patients for COVID within 24 hours of taking them to the operating room. Some problems include the fact that there is a false negative rate to this testing. Some people feel it's as high as 20%. And again, in some of the European studies, patients who were thought to be COVID negative, as many as 1/3 of them went on to, in fact, become, or we figured out they were COVID positive, and many of those patients died post-operatively. So this is a particular risk for our patients and helps us to understand what we should do now and what we should wait for. You know, everything we do in medicine is benefit risk, whether it's surgery or systemic therapy or radiation. And I think now that ratio includes the risk of surgical delay versus the risk of a COVID infection or post-operative outcome. And we factor all those in to how we advise our patients and how we take them through their journey with cancer. Next slide, please. So this paper was presented at the AACR meetings 2 days ago, April 28th, and published simultaneously online. And the reference for that is in the upper right for this. And this is from the Wuhan experience in China. And it includes about 120 cancer patients. If we go to the next slide, on the left, what you can see is the percentage of patients who had either death, ICU, or severe critical outcomes, and how many needed intubation and respiratory assistance. And this is by type of cancer. And what you can see is that patients who had hematologic malignancies were the most likely to die or end up in the ICU or have severe complications. And that was followed by lung cancer as the second most common. But in fact, all cancer patients had an increased risk of all of these complications. As you can see, the blue bar on the left are the non-cancer patients, and they fared much better. The graph on the right shows the rapidity of developing severe events. And the green line at the top are patients who had advanced and metastatic cancer. And you can see that the likelihood of them developing severe complications was much higher than those with non-metastatic cancer or non-cancer patients. And the rapidity with which they got there was marked. And so all of us have learned when we take care of patients who become COVID infected and have cancer that we're particularly cautious because their course is likely to be more rapid. Next slide. So the NCCN, a group of us, including myself and others, published this in the Journal of the National Comprehensive Cancer Network, or JNCCN, and this was published a couple of weeks ago. And this outlines how we think about the interaction between healthcare workers and oncology patients, because they're intertwined. We need to keep our patients safe. We need to keep our healthcare workers safe. And in this article, which I would refer you to, we give a lot of recommendations, which I think we're hopefully all following at this point, about precautions, PPE, social distancing, how to keep patients out of the office and out of the hospital if we can, and so on. So this is a reference that I think can be helpful for you. Next slide. So a couple of things to think about. What we've done at my institution, and I'm going to show you some examples of that, is we've tried to prioritize what our patients need, and that helps to determine who needs to be brought in now for care and who can wait and have their care delayed until we think it's a safer time for them to come in and get what they need. This is an article that was published in JAMA a couple of weeks ago by Deb Schrag and her colleagues, and she divided things up into 4 prioritization levels. Prioritization 1 was care that was not time sensitive and could be delivered remotely, and that might be survivorship care for a patient who had no symptoms or indications of having a problem. Prioritization level 2 was care that could not be delivered remotely, but omission or delay had little effect on the quality or quantity of survival. And in this group, we might include bone agents, such as denosumab or zoledronic acid, used for metastatic disease. And in my institution, we've delayed those therapies until we feel it's safer for the patients to come in and get them. Prioritization level 3 is delay of care has a moderate effect on quality and quantity of life, and this might be an adjuvant therapy for breast cancer or lung cancer or colorectal cancer, where long-term survival benefit is about 5%. So there is a difference. It's not huge, and you have to weigh that against the risks to the patient. And finally, level 4 is treatment that cannot be delayed without adversely affecting the outcome. This might be chemotherapy for acute leukemia or for testicular cancer, care of patients with complications such as hypercalcemia, neutropenia, and fever, or spinal cord metastases. Next slide. Several weeks before this, Cancer Care Ontario came out with a document that is here and is available for you online. Pandemic Planning is a clinical guide for patients with cancer. And if you go to the next slide, they broke things up into 3 priority categorizations. Priority A, patients who are critically ill who required immediate care. Again, these might be situations such as hypercalcemia or neutropenia and fever, spinal cord compression. Priority B were patients who required services or treatment that really modest delays would not have a major effect, but major delays would. And priority C were patients who were generally healthy, whose conditions were not life-threatening, and if therapy was delayed, then it should not have a major impact on their overall outcome. Many of us in the US have been using this grading system, and I'll show you an example of that next. Next slide, please. So a group of us got together, including myself, from the major national organizations who are interested in breast cancer, the National Accreditation Program for Breast Centers, or NAPBC, the American Society of Breast Surgeons, the Commission on Cancer, which I represented, NCCN, and other organizations. And we developed a prioritization scheme for the triage of breast cancer patients during the pandemic. And this was published a week or so ago in the Breast Cancer Research and Treatment Journal, and the reference is on the top there. And we use the Ontario categorization. If you go to the next slide. This is hard to read, but I'll just give you a couple of examples. We broke it down into imaging, surgery, medical oncology, and radiation oncology, and this was the table for medical oncology. You can see in priority A are patients who have oncologic emergencies like hypercalcemia or brain metastases requiring immediate treatment. Priority B, where slight delays were acceptable. We broke this down into B1, B2, and B3. An example of a B1 priority would be patients with inflammatory breast cancer newly presented. B2 might be patients who are receiving treatment for stage 1 HER2 positive breast cancer. And B3 might be patients who are managed for ductal carcinoma in situ, or patients with metastatic breast cancer who have had multiple lines of therapy where additional therapy is not likely to be helpful. We did this again for all the specialties. If you go to the next slide. So what have we done at Penn? I think this has been a reasonable way to approach this. We are, like many academic centers, organized around disease teams. So we have a breast team and a lung cancer team, a GI cancer team, and so on. We charged them all with forming COVID multidisciplinary teams, including the clinical specialties as well as pathology, radiology, and associated other services such as pulmonary for lung cancer or endocrine for thyroid cancer. And all of those teams, in fact, formed the COVID team within a couple of days of being asked. And those teams have been meeting now nearly every day to sort out the situation. We asked them to create COVID-specific pathways for dissemination throughout our network. We have 6 hospitals in our network and multiple ambulatory sites and affiliated practices. And these pathways have been distributed throughout all of them to help our colleagues, along with ourselves, to navigate our patients through this pandemic. And again, we balanced the needs of the patients in regard to their cancer, what we thought the infection risk was for them, and also the constrained resources at our own hospital. And at the height of our pandemic at Penn, we were concerned about our ability for ICU capacity and ventilator capacity. And so major surgeries that would require ICU care and ventilator care, if we could, we would put those off. Things are coming around the corner, and I'll talk about that in a couple of minutes. We also altered a lot of the systemic therapies, sometimes stretching out the intervals between treatments, frequently switching from intravenous therapy to oral therapy when that was possible. And we also now have a robust treatment at home program where many of our patients are receiving their treatment at home, so they don't need to come in to into the hospital, into our clinics. Next slide. We also created patient lists in our electronic health record and created a smart phrase, which I'll show you, which basically documents which parts of their treatment might have been delayed and what the prioritization is to bring them back when our ability to do that is greater. So a patient who has lung cancer and needs surgery is going to be high priority. A patient with ductal carcinoma of situ of the breast can wait longer and will be a lower priority. We've also developed REDCap databases to capture details of treatment. And I would just mention that the National Cancer Institute and the cooperative trials groups, as well as FASCO, are all developing databases for COVID-infected cancer patients that I would suggest you consider partaking in. Next slide. So this is our smart phrase. I'm not going to spend a lot of time on it, but basically it says, due to COVID-19 risk and capacity constraints related to the management of COVID-19, Mrs. X has the following components of her treatment delayed. The answer could be none. But if you pick that there was a delay, it asks you to answer which component of the treatment was delayed, and then prioritize when that treatment needed to be administered when possible below. This gets captured in the EHR and structured data so that we can track all of these patients and bring them back when appropriate. Next slide. This is just a screenshot of one of our pathways. This happens to be for lung cancer. It starts with interventional pulmonology, goes through surgery, medical oncology, and radiation oncology, and follow-up care. And this is quite detailed, as you can see here. And for those of you interested, on the next slide, this has been accepted for publication in JCO's Oncology Practice Journal and should be out momentarily, and includes all the details in our document. This was also run through some ASCO processes, and they've endorsed it as well. So like with the breast document that I showed you earlier, this document, there are a growing number of these that are available to you to help you sort out how to prioritize the care of your patients. Next slide. So one last thought here. We're starting to do post-pandemic planning. I don't think any of us have a good idea of what the downslope of the pandemic is going to look like and how we're going to manage it. Our conclusion in some of our national forums and at Penn is that it's going to be more complicated than the shutdown that we did early in March, and we're all trying to figure it out. It's likely that the virus will not disappear, and we're going to have to continue to manage our sites of care as far as infection control goes, safety of our patients, safety of our staff. We'll again need to weigh the risks of infection spread to patients and staff, and weigh that against further delays in surgery or systemic treatment or radiation. We'll need to consider our resource constraints and public health concerns as well. So this is going to be a complicated process that all of us believe will change week to week, and will also be dependent on where you are in the country and what your burden of COVID-19 infected patients are. I think that might be my last slide. So thank you very much for your attention, and we're looking forward to your questions and thoughts.
Great.
Back to you, Laura.
Yeah, great. Thanks so much, Larry. And thanks for the presentation. Agreed that I think the post-pandemic planning is going to prove to be more complex than the beginning of this, but we'll be all working on that together and learning together. Thank you for the resources and suggestions on all of the recent literature that's out there to help with both current issues as well as looking towards the future and how to re-engage in care where care's been delayed. Be sure to submit your questions about the didactic or other general questions to the Q&A portal. We're going to transition now to the question and answer part of today's call. So I'm going to start with a pre-submitted question, and then I'll get to some of the live questions also. So the first question is really about social distancing requirements for health workers. So the question says, I'm interested in the social distancing requirements for health workers. Should I remain isolated from all family members not in the household? My concern is for the long run and what type of standards for myself and staff in an oncology clinic. Would one of our panelists like to take a stab at that? Or Dr. Brooks from the CDC perspective?
Yeah, I can. That's an excellent question, first of all, and it's a very difficult question to answer because there's no one size fits all, unfortunately. I think that many providers, and I'm talking across the range of allied health professionals who may encounter patients who are immunosuppressed or being treated for cancer or survived and may still be at increased risk for severe disease if they became infected with COVID. It's difficult to know what the right thing to recommend is for each individual person. In general, if you are going to be, if you're able to use PPE and you doff it, take it off properly and maintain the proper hygiene, that should protect you from bringing home the infection to household members. However, that being said, there are some people who still feel, I think they feel better if they do something to maintain social distancing at home, and that it's hard for us to know to what extent people have brought infection home from the healthcare setting to infect their household members when there's community spread. And especially right now, we're looking into that, but we haven't got any good data to inform what the individual risk might be. But I was going to say that for those for whom it would give them an extra sense of safety and they're able to socially isolate at home from their family, we wouldn't say that's a wrong thing to do and could endorse that.
Great, that's helpful. I don't know, Mark or Larry or Tom, any suggestions or ideas from how you're handling this within your settings?
I guess I would say, this is Mark, I would add maybe one other thought, and that relates to what your state rules are. For example, in Washington state, there is an order that you can't travel outside the home except for essential needs and work-related issues. If you look at Tennessee, they're advised to stay home, but it's guidance, it's not an order. And there are differences in terms of the two states, including things like places of worship, weddings, and funerals. Tennessee allowing that, and Washington state not allowing that. There's a nice article in the Wall Street Journal this morning that actually goes through each state for the lockdowns and the plans for ramping up again. So it's a good reference if you want to consult that.
Yeah, I echo what Mark says, and I think that this question also will be addressing next Tuesday's webinar as well, because I know that Larry kind of ended his presentation with that, but it's really about, you know, there was a phenomenal article in The Atlantic that came out by Ed Young that talked about and it actually served as kind of a conversation piece for us in the NCCN Best Practices Committee. It's the question isn't when do things get back to normal. The better question is how do we continue? You know, and we anticipate that there's going to be this environment where there's going to be, you know, some level of COVID infection. And that's why I think what Mark reiterated, that you really have to pay close attention to your local and state governance and see what the activity of the community infection is. Because yes, there are general guiding principles, but every community is going to have a little bit of nuance and variation that we have to keep in mind as well.
Great, yeah, thank you. Yeah, the local situation will clearly be so important, remain important as we continue on. And that's a really important point. I think this idea of getting back to normal is probably fading more quickly than we want to say, but it is, and we need to be looking about how we can continue to care for our patients and our communities and our families. On this idea of social distancing and protecting others, we have a question about the use of masks. The question is, does a patient who has recovered from COVID-19 need to wear a mask in public?
Well, I'm happy to take the first stab at that question because I get asked that about 50 times a day, you know, in various different forms. So just so everyone's clear, the reason we recommend masks for persons in public is to prevent them from inadvertently transmitting infection to others. It's what we call source control. That is to control you as a potential source of infection from exhaling virus and giving it to others. A couple of things on this point. To answer the question quickly, no, we would recommend that even if you've recovered, you should wear a mask in public. The first reason is that early after recovery, we know that there are still people who continue to shed virus that's detectable. We don't yet know how long they shed infectious viral particles. And our experience with other upper respiratory viral infections would say that at some point you stop. But at least in the short term after recovery, you definitely need to have that source cover for a couple of weeks just to make sure. The other important point here, though, is that we can't assume that recovery from infection confers immunity from reinfection. I'd like to believe that were true. I'm hoping that's true, but we just don't know. And I'm afraid that we have numerous examples of diseases where after recovery from the infection, you can become susceptible to it again. I'll just note that there used to be 6 known human coronaviruses, and now there's 7. And of 4 of them are ones that are often referred to as the common cold coronaviruses. And we know from studies going back to the 1970s that people who've had one of those 4 infections, which I'm sure bedevils some of you in the oncology field, after a few years, even as less than 1 year, the immunity you develop against that particular genetic strain can wane and you can be reinfected with that same strain. We're hoping that's not the case here. I'll add that we don't know enough from SARS and MERS, to which this virus is more similar, to know if reinfection is possible. SARS was only circulating in humans for 1 season, so there wasn't a lot of opportunity for reinfection or to do observational studies to see if it could happen. And MERS occurs very sporadically, and it's hard to, there's not enough incidence of disease or density of incidence to know whether people can become reinfected yet. So yes, we'd encourage you to wear it. And just the very last reason is it sets a good example. It tells people that you care. And we know from both anecdotal as well as some nice research that if you wear a mask, people will stay farther apart from each other.
That's an
Yeah, I would just
point.
add, if I could, there's anecdotal evidence, and this is really still anecdotal, that some cancer patients may harbor the virus for very long periods of time. 6 or 8 weeks is as long as we've been measuring for some of these people. I don't think we know, John would know much more about this than me, whether they were at risk to still infect somebody else. We also don't know how that might interact with treatment that we would like to reinitiate with them once they get past the infection. But what is clear is if you continue to nasal swab them, you continue to get positive results. We just need to figure that out.
I mean, that's the call we get all the time is once you engage in testing, a certain fraction are going to go on to be what we are beginning to call persistent shedders. And in fact, a study this last week in clinical infectious diseases documented that some people can shed, and these are immunocompetent persons who all had experienced only mild to moderate illness, can shed for up to 6 weeks. I'll just add, I'll put this out there, if any of you all have data from persons living, treated with, or recovered from cancer about how long they can shed, that would be very valuable. We presume that, as with many other immunocompromising conditions, that people will shed this virus longer than otherwise healthy persons, but it hasn't been well documented. And if you're able to do culture for virus, that is the gold standard. If you can't recover what we call replication competent virus, then it's likely that's not infectious material.
John, if you have 2 negative PCR tests 24 hours apart after someone recovers from a COVID infection, is that sufficient to say it's highly likely that you're not shedding, and
Yes.
that you would change maybe your recommendation on wearing masks, or would you continue that recommendation?
Well, first of all, I would continue the recommendation because we don't know what the masks also do we do believe they have some small element of preventing you from becoming infected, but they're not the most effective. I mean, it's the N95s that we want to keep reserved for healthcare that are most effective. But there has been some research looking at surgical versus hand-sewn cloth mask versus an N95 versus a elastomeric kit, and all confers better than 0 protection. So I think that alone would merit it, especially for someone who is in the undergoing their journey with cancer or who has recovered and survived cancer. In terms of the 2 negatives, that's our standard for determining that on a test-based strategy that you're cleared or recovered from infection. But there are many cases of people who, after they've done 2 negatives, somebody went and tested them again. And they came back positive. The Koreans are seeing this because they have a lot of easy access to no-cost testing. And so a lot of people are just showing up to test themselves, and they're finding these positives. We think they don't represent people who are infectious. Of 6 persons in this sort of scenario who had cultures done, they were negative. And the viral burdens, which we measure as cycle thresholds, is very low, but it's detectable.
Thank you.
Thank you. It's super important and beneficial to just understand more of both the testing strategies, the ways that we will see persistent shedders, and how to kind of navigate that. Let's continue this thread of sort of the distancing, the wearing of masks. We have a question about what to do about infusion suites, which is similar with how patients may be close together. So the question is, what are your recommendations for patients that are coming to infusion suites when the chairs are close together and the waiting room may be full?
Well, this is Larry. I mean, what I can tell you is that our waiting rooms are not full, that we've scheduled people in ways that, in fact, the waiting rooms are quite sparse. The seats have largely been removed, and the ones that are still there are within safe distancing from each other. We've, worked hard at scheduling and how to, have patients come in a way that they don't have a lot of time to wait. And we also have a no visitor policy. So in the old days, you used to come with your spouse or your, mother or whatever. And so just the raw numbers of patients coming into our units and their family members are greatly decreased. We're not, if you go to our units now, it looks like a ghost town. There's just not a lot of people hanging around. And likewise, in the infusion units themselves, though our infusion units are running at about 80% of normal capacity, we've managed to, in fact, spread things out in ways that people are not close to each other. And since they're not bringing family members in, that has helped a lot as well. I think the challenge is going to be going forward as we start to bring more people in, how are we going to maintain the lack of crowdedness and the appropriate social distancing for our patients, both in the waiting rooms and in the exam suites and in the infusion suites. And we're trying to figure out how to do that from a mechanical point of view.
Yeah. I'm sorry. Yeah, I agree with everything Larry said. And then the other thing that I would add is we actually got this idea from Starbucks. That is, when you on the ground have physical markers that say this is 6 feet apart, it actually helps a lot. We thought when somebody pitched it to us initially, we thought it was the corniest idea ever, but we've actually found it's been incredibly helpful. And so part of it is, just like Larry said, about mechanical kind of reconfiguring your spaces so that you space the chairs out a little bit and see how things are. I mean, it's not perfect solutions. Obviously, there's going to be some where maybe it's 4.5 feet rather than 6, but things like that can also help as well.
I think the other thing that we're doing, and I suspect many others are too, is of course rigorously pre-screening patients who come in, our healthcare staff who work. We have a really, really tight system where we call people 24 to 48 hours prior to their clinic visit to screen them, and if they are symptomatic, they go through our car-based screening process so that we actually have the results before they enter the clinic. So we're starting there to try to keep our areas, including our infusion areas, as safe as possible. We have mostly individual rooms for our infusion area, but we have some chairs, and those chairs are separated by curtains, for better or for worse. And of course, for patients who are positive or who are symptomatic and undiagnosed and need to come into the clinic, we have special areas that we've cordoned off for managing those patients.
Great. Those are all helpful tips. I think the markers on the floor do seem like they make a difference. I've noticed it makes a difference in my own rare occasions that I've been out. It has made a difference for me too. And in the healthcare system makes good sense. Anything else to add on that, sort of the physical distancing and how to handle the flow of patients? Anybody else have anything to add on that topic? Okay, let's shift gears a little bit to go back to your didactic presentation, Larry, and around the various ways to think about who should maintain treatment, who needs treatment now, who needs visits now, who can be delayed. And the question is, Dr. Shulman, you identified a group of patients with metastatic cancer who were status post multiple lines of therapy, for whom further systemic treatment is unlikely to work, as being in the category where therapy can be deferred for some extended time or some period of time. Does this not raise the issue of whether in a non-COVID-19 scenario, those patients should resume active therapy at all?
So I think that's really a critical question. And, you know, that's been an area that we focused a lot on in this country, as you know, and there is concern that we're providing feudal care that carries with it toxic effects and detriment in quality of life rather than improvement. We live in a country where, you know, if you have and we have patients who come in with that mindset, they feel like they have nothing to lose, give that fourth line or fifth line of therapy a try. Maybe they'll be the lucky one. But in fact, it doesn't make sense. And I think that there are data to show that we probably do provide care that causes more harm than good. And as you might know, some of our quality metrics that we're now using for the Commission on Cancer and for other agencies measures chemotherapy in the last 2 weeks or last 4 weeks of life, and trying to show that in your cancer program, in fact, you're not using chemotherapy or other toxic treatments at the 11th hour. One of the things that we've done at Penn is that we've increased our use of what we call serious illness conversations with patients earlier on in their therapy. And we used to do all these in person. Now we're actually doing a fair amount of them by telehealth with video conferencing with the patient and their family, and aligning the goals of care for them and what we think should and shouldn't occur. This is something probably that we should have done more of before, but as the person who asked the question suggests, this is really called the question in this circumstance. So yeah, one of the things that we want to have come out of this, there should be a few silver linings, is helping to reorient how we provide care, and this is an example of that.
Thanks,
Yeah,
Larry.
I would agree with Larry also. This has accelerated the serious conversations that we've had here in Seattle with our patients. This has given us a good opportunity to do what we had planned already, and that is to develop an approach called Vital Talk, which is a national effort to help with these conversations. As I understand it, MD Anderson has almost mandated that these conversations occur as a result of this pandemic. And then the last thing, and here in Seattle, thankfully, we think we're over the peak. But prior to the peak, we were worried that we would get into a situation where we would lack the resources in terms of ICU support to be able to care for patients. And in that situation, the state of Washington has what's called crisis of standards guidelines that they can actually mandate should that situation occur where the primary physician no longer is the major person determining who would be able to receive those resources. So again, trying to accelerate these conversations in anticipation of trying to avoid those very difficult situations that might occur at the last moment and be decided by a triage committee is something we wanted to avoid. Thankfully, the peak is past here in Seattle, and it's looking better.
Can I just add one thing? I think that's a really important points made here in conversations that need to be held. And in general, we have also been recommending that this epidemic is providing an opportunity for many people to revisit what their wishes would be at the end of life. And so I know perhaps with cancer, I'm not sure how that's typically introduced with people, living with cancer, recovered from cancer. Certainly in my experience, with HIV, we have this. We're thankfully not having that conversation as frequently or as young in age as we used to. But people worry a lot about this issue with death panels, as Mark's pointing out. Many jurisdictions have these plans in place so that were limited ventilators available, there are priorities of who gets it first. And having thought through a decision about what you'd like to do while you're still clear it can help very much if that decision ever were to come up.
Mm-hmm. Yeah, so important. Thank you for the question. And I think these are really critical conversations to have in these settings among healthcare professionals, and then to be having with our patients. You know, this is an area of medicine that maybe we've all hoped and wanted to do better at, and this is an opportunity to help families and patients navigate the end of life, or things that maybe not, the risk benefit ratio may reverse on us. So appreciate the question and the comments. I want to just shift a little bit and think about patients who maybe have recovered from COVID or were in the hospital for other reasons, for some reason, and are going home. The question is about, what are your recommendations about to patients that have recovered after they have gone home on how to interact with their family within the home?
This is a challenging issue, and I think that part of it is that at least in our state and in the Mountain West region, we're seeing that unfortunately this disease is affecting more minorities and those who've been historically disenfranchised. You know, general recommendations are, please designate like one primary caregiver who would be with you, and then kind of, at least in the recovery period of time, you know, it continues socially distancing and potentially quarantining, because as has already been related, we don't know how long the virus particles are still shed, and we don't know if that means that they're infected or not. And so those are kind of the general things. But let's say you have a family that is, you know, 10 family members living in a 2,000 square foot area. Social distancing in that region is incredibly challenging. And I think the honest answer is it's ongoing work. We have general recommendations. We've been following the CDC and other entities, but it's challenging, to say the least.
Mm-hmm.
No, I agree. John can probably comment on the CDC guidelines for this, but I think one of the important things is when you identify a caregiver at home, that it's shouldn't be someone who is in a high-risk category for having a poor outcome should they develop a COVID-19 infection. There are lots of recommendations for how to manage people, including separate bedrooms and bathrooms for that person, being very careful about sharing space, avoiding visitors, staying separate when possible if someone is really sick, and then lots of guidelines about doing laundry, washing utensils, etc. Those are all probably worth going over if you have such a situation in great detail, because I think the guidelines the CDC provides are quite good.
Yeah, the only other thing we'd add is we've actually tasked our social workers to check up on these families every single day. And thank God for them. I mean, they've been a lifeline for us because, you know, they're, you know, instead of just waiting for some problem happening, they're just ongoing monitoring and checking with these patients and their family members every single day to see. And we've been fortunate, we've been able to actually catch a couple of close contacts who started having symptoms and brought them in for testing early by doing that. That came from that social worker surveillance there. But we also have the luxury of being able to do that because we haven't been hit as hard as Seattle or New York or other places around the country. And so we've had the luxury of learning from other experiences and putting things into place that way as well.
Yeah, so important. Go ahead, Larry.
I would just add, you know, there's also the concern that people do better, they go home, and then something happens from a medical point of view. And we know about a certain number of patients who have had fatalities, died after going home, seeming like they were on the road to recovery, and then ended up doing poorly. And whether that's due to myocardial damage or other organ damage from the virus, I'm not sure. We're always 100% sure. At 10, we actually have something called COVID Watch, which is a smart app that texts all of our COVID patients twice a day, 8 a.m. and 4 p.m., and checks in on how they're doing and asks them a series of questions. And if they answer in a way that's concerning to any of the questions, they get an immediate call back from one of our COVID nurses. So we are trying to keep track of them and see how they're doing.
And if folks want to find those guidelines for home care, I know our website can sometimes be a little difficult to navigate, but if you go to Google and type CDC COVID-19 home care, it'll take you directly to that guidance.
Oh, that's great. That's great to know, John. Yeah, helpful to be able to just go right there. And that seems like a great resource to help send with patients as they go home. Also, you know, interestingly, like similar to some of the other conversations we've had today, this whole idea and need for discharge planning and close post-hospital follow-up maybe has been highlighted more than ever now. So it's great to hear about utilizing our social workers and our teams and how important that part of our healthcare system is and the real benefit there. And I love, it's so interesting to think about the idea of our you know, care coordination or discharge follow-up really being a part of how we will start to figure out contact tracing even more, and the benefit in really leveraging those resources that you're using for other things to start with helping on the contact tracing part of things too. So thank you for everyone's comments there. I'm watching our time and we have lots of great questions. So I'm gonna transition us to talk about kind of a nitty-gritty clinical question, because I think this would be beneficial to everybody and may get into some of what Larry shared in the didactic about which patient, what kind of follow-up is necessary right now, what kind of follow-up can be delayed, and all of that. So the question is this: should a young patient who finished chemotherapy 6 months ago for Hodgkin's lymphoma, currently asymptomatic, go for a 6-month follow-up PET scan or wait? Good question. I see
So,
you know, these are the tricky situations. So go ahead, Larry.
Yeah, you know, so I'm primarily a breast cancer doctor, not a Hodgkin's doctor, but I know a little bit about the disease. And actually, you know, this is where the subtleties and tumor boards actually really help. We can usually classify those patients as whether they're likely to be cured or likely to have a recurrence by their scans during therapy, usually after a couple of cycles of therapy. If this person was in a good prognostic category with a high likelihood of cure, I would try to keep them out for a while and sort of see how things played out over the next several months. We think that Hodgkin's patients are particularly prone from the hematologic malignancy data I showed you from China, particularly prone to serious or fatal complications from COVID. So they're at very, very high risk if they were to become infected. For the patients who had worrisome signs during their initial therapy and we felt was at high likelihood for relapse, we might bring that patient in. That's, again, it's always benefit versus risk analysis for each individual patient.
Yep. Yeah, that risk benefit kind of discussion and the thinking through it is always, well, what clinical medicine is all about, right? I think we said that last time.
Yeah, and I would just make another comment. I mean, you know, we do a lot of things out of habit. There was a very interesting study about a year or so ago from France with patients who had advanced lung cancer, who either were followed like we usually follow them with CT scans every 6 months, or basically just given patient-reported outcomes every month to let us know how they were doing. And actually, the patient-reported outcomes group performed better, which is to say we picked up advancing disease earlier, and actually their survival overall was better. So, you know, we're used to doing scans, but sometimes just staying in touch with your patients and getting routine feedback from them about how they're doing can be a very valuable way to monitor them and avoid having them come in for scans. Yeah, one other thing I would say, though, with all of this, and we've seen this play out not only in cancer, but in heart disease and others, is if you need to be seen and you're not doing well, you should talk to your doctors and come in and be seen. And we're seeing a lot of patients who should have been seen weeks ago, didn't call, were afraid to come in, and now they're in a much worse situation than they were before. So, you know, be in touch with your healthcare providers. Telemedicine is a great way to do that, and then they can help to work out with you in fact, whether you do need to come in person or not. So we don't want patients not to come in when they need to come in.
Yeah, Larry, I think that fear factor is something that's played a huge role here in both the upswing and now the downswing. In the upswing, we were worried about having enough resources, but actually patients preferred not to come in, and we had more resources than we thought. And likewise, now in the downswing, you know, we're worried that maybe patients won't come back as quickly as we think it is possible, given the safety precautions that we put in place. So managing that fear factor is something that we're focusing on right now, because we think, at least in our clinic, it's very safe.
Yeah, that's great. I think that fear factor, we touched on that on Tuesday, but for those who weren't able to join us then, that just it's worth reiterating, helping patients understand that when they need to come in, they should, and that we want people to access care when needed, and staying in close contact, especially with those who may be on our higher worry lists, can make a big difference. Anything to add on that, John? Yeah, go ahead.
I was just going to say, I completely agree. We're seeing this also in other areas like heart disease, where people are, where there's very sobering data from Europe of people, you know, found dead at home, with declining ER visit rates, which we're also seeing nationally now in the United States, more people being found dead outside the hospital from preventable disease. I guess the other point I would just make here is that it's also important to communicate to your patients that you can take care of them safely. I think what they fear a lot is the idea, well, I'll come in there, but I could be exposed to somebody who may drift by if I was in that, because they may not have been to see the infusion room has been spaced out and that people are using PPE properly. So giving them that permission to come in and reassuring that they'll be taken care of safely can be helpful as well.
Yeah, thank you. That's a great point. We'll use that as our summary point and our ending point today. Thank you to everyone who has joined today. I'm going to hand it to Rich in a second to just wrap us up. Quickly, there were a couple questions about, can the article list from today's session be shared? And we will send an email to all of the registered attendees with the list of the articles that Dr. Shulman shared, as well as a link to CDC. And there was a request on Dr. Stewart about the Vital Talk program that you all are implementing also. So we can include any resources around that as well. I'll hand it over to Rich to just wrap us up today. And again, say thank you for joining. We appreciate the conversation. Hope you learned something and have some good practical tips to take back to your settings. You're muted, Rich.
Perfect. Yep.
There you go.
Thanks, Laura. Yes, thank you. This was a great conversation today. We will definitely be following up with an email with the link that Laura mentioned, also with the link to the recordings for today's and Tuesday's session. But please do join us for our final session of this 3-session series on Tuesday, May 5th, same time, 12 Eastern. We will be discussing steps to take to re-engage patients as the pandemic subsides. Of course, we'll be answering a lot of the questions that we're receiving today, the ones that we didn't get to answer today. Also, a heads up, you still have an opportunity to drop some questions in the question and answer portal that we might be able to get to on Tuesday. If you don't have time to do that today, please do consider completing the post-survey evaluation for 2 reasons. One, we want to know how this is working and what you like and what you don't like so we can improve future sessions, but also it gives you yet another opportunity to submit questions for our expert faculty panel to be able to address. So thank you so much for the discussion today. Thank you for joining today. Appreciate everybody's attention and questions as they've come through, and look forward to seeing everybody Tuesday, May 5th at 12 Eastern. Thank you so much, everybody. Have a wonderful day and a great weekend.
Thank you.
Thank you.